Hello everyone, welcome to the Anesthesia School. My name is Ruslan. We're finally launching a project that has been on our minds for quite some time, but that we've never managed to bring to life. To ensure our presentations reach a wider audience, we will be presenting some topics in English. It is not our native language, but we've been using it for quite some time, both in our professional lives and our daily practice, and many sources are in English as a matter of fact. And I personally prefer to read resources in their original language. So I don't think there will be any shortcomings regarding the language itself. There might be an issue with our accent or the tone of the voice, but that is to be expected. After this introduction, let's get to the main topic. Today we will be discussing cerebral circulation. We previously published a Turkish presentation on this topic, actually. In fact, it was our very first video on this channel. Now let's try it in English. That was actually another goal of ours, to see whether we can do it in English or not. The quote that you saw in the previous slide served as a beautiful motivation for us, and I hope that it will serve as a good motivation for you as well, if you are planning to do something. I hope you benefit from this video. Enjoy listening. Although there are very important clinical considerations, this topic is primarily presented as an anatomy question in most cases. Therefore, drawing an explanatory diagram is always a good idea. No one will criticize your drawing skills. A simple schematic drawing not only helps you to convey your knowledge more effectively, but it also engages your visual memory, making it easier for you to grasp the topic right from the start. After discussing arteries and veins, it may be necessary to touch on some clinical aspects, for example, intracranial aneurysms, vasospasm following subarachnoid hemorrhage, the physiology of cerebral perfusion and intracranial pressure. Starting with the arterial circulation, the brain is primarily supplied by four vessels, two internal carotid arteries and two vertebral arteries. The carotid arteries supply blood to approximately the front two-thirds of the brain, while the remaining one-third is supplied by the vertebral arteries. Some sources state that this distribution is actually 80 to 20. Anyway, the posterior inferior cerebellar artery, the pica, and the anterior inferior cerebellar artery, the AICA, arise from the vertebral arteries. These two vertebral arteries then merge to form the basilar artery. You can see numerous pontine branches emerging from here. Next comes the superior cerebellar artery, followed by the posterior cerebral artery. These constitute the posterior circulation. They anastomose with the anterior circulation via the posterior communicating artery. In the anterior circulation, there are the middle cerebral artery, MCA, and the anterior cerebral artery, HCA, both originating from the internal carotid artery. Anterior carotid arteries join with the anterior communicating artery. The complete union of these structures is called the circle of Willis. Of course, it is not always perfect. In about 15% of cases, it is incomplete. This anastomotic system provides an effective collateral circulation, and even the occlusion of 3 out of 4 main arteries may not cause a problem, provided the process develops slowly. Now let's have a look at the venous circulation. Superficial structures, namely the cortices, drain into the dural sinuses. These venous sinuses are located between the two layers of the dura mater. The superior sagittal sinus drains into the right transverse sinus, then into the sigmoid sinus, and finally into the internal jugular vein. The inferior sagittal sinus drains via the straight sinus into the left transverse sinus, then into the sigmoid sinus, and finally into the internal jugular vein. Deep structures drain into the internal cerebral veins, which in turn form the great cerebral vein, the Galen vein, and drain into the inferior sagittal sinus. The cavernous sinus is located on either side of the pituitary fossa, also drain into the transverse sinuses. Intracranial aneurysms account for up to 85% of subarachnoid hemorrhages. It's important not to confuse subarachnoid hemorrhage with other types of hemorrhage. As a reminder, epidural hemorrhage originates from the middle meningeal artery, while subdural hemorrhage originates from the bridging veins. The subarachnoid hemorrhage we are discussing here, however, originates from the cerebral arteries we mentioned earlier. Mortality is around 50% and morbidity is also high. They result from thinning of tunica media in the arterial wall. They typically occur at vascular bifurcations and are mostly located in anterior circulation. Only about 10 to 20% are in the posterior circulation, namely the vertebral-basilar circulation. The primary management strategies focus on cardiopulmonary stabilization and preventing secondary brain injury, followed by endovascular interventions such as coil occlusion or neurological procedures like clipping. There are various grading scales for subarachnoid hemorrhage: the clinically based Hunt and Hess and WFNS scales, and the radiologically based Fisher scale. However, we will not discuss these today. If you'd like to review the details of these scales, I will include a link in the description section where you can explore them further. You can also see the link below. Cerebral vasospasm is the primary cause of morbidity and mortality following an aneurysmal subarachnoid hemorrhage, and this occurs in up to 70% of patients. It typically begins within 3 and 10 days after the event and usually resolves spontaneously within 21 days. Several theories exist regarding its pathogenesis. One of these involves elevated calcium levels and the resulting vasoconstriction. On the other hand, it may also be related to the increased calcium responsiveness rather than the amount of calcium itself, because in these patients there is upregulation of the endothelin-1 receptor, which is associated with an increase in calcium responsiveness. Other theories include reactive oxygen species, lipid peroxidation, and changes in nitric oxide metabolism. The cornerstone of vasospasm management is nimodipine, a dihydropyridine class calcium channel blocker. Nimodipine is typically administered at a dose of 60 mg orally every 4 hours for 21 days. The primary basis for this treatment is the British aneurysm trial conducted in 1989. In that study involving approximately 550 patients, a reduction in morbidity of about 40% was observed. You can view the study here, and I have included a link in the description sections. You can also see that reference below. The Triple H principle is recommended for the management of cerebral vasospasm, and this is hypertension, hypervolemia, and hemodilution. The primary goal of this treatment is to increase cerebral perfusion, reduce blood viscosity, and thereby maximize cerebral blood flow. However, control studies on this topic have yielded controversial results. For example, while a low hematocrit may increase blood flow, it will reduce cerebral oxygen delivery. Personal factors that may vary from patient to patient are likely important here as well. Finally, let's discuss cerebral venous thrombosis. The female to male ratio is 3 to 1. Pregnancy and the puerperal period are significant risk factors. The incidence in this patient group is 1 in 8,000 and diagnosis is likely to be missed. Therefore, it must be included in the differential diagnosis of peripartum headache. Other risk factors include obesity, malignancy, thrombophilias, and COVID-19. It presents with signs of increased intracranial pressure like headache and nausea, as well as visual disturbances, papilledema, seizures, and focal neurological deficits. That's all for today. Thank you for listening. See you in the next video. Goodbye for now and have an excellent rest of your day.